let's talk about heparin. It's one of the most common drugs you'll find in any hospital. It's a fantastic blood thinner, used all the time to stop deadly blood clots. But what if I told you that sometimes this life-saving drug does a complete 180 and starts causing the very clots it's meant to prevent? Yeah, today we're diving into a fascinating and dangerous medical paradox. So this is the big question, right? How is that even possible? It sounds like it makes no sense at all, but for some people, it's a terrifying reality. We're talking about a situation where the body's own immune system gets tricked, gets confused, and launches an all-out attack that has absolutely devastating consequences. So to really get our heads around this betrayal, we need to first understand the condition itself. It's got a mouthful of a name, heparin-induced thrombocytopenia, or as we'll be calling it, HIT. Okay, now what's so wild about this definition are those two parts right next to each other. A drop in platelet counts, which, normally makes you think about a risk of bleeding, and a high risk of blood clots. It's this bizarre, contradictory combination, all driven by the immune system, that makes HIT so incredibly dangerous. Now, it's super important to know that there are actually two types of HIT. Type I is pretty common, it's mild, and it's not an immune reaction. The platelet count dips a little, then it bounces right back. No big deal. The one we are laser focused on is type 2. This is the rare one, the severe one, the one where the immune system goes haywire and creates life-threatening clots. This is the real deal, the one where you have to stop heparin immediately. So how big of a deal is this, really? Well, up to 5% of all patients who are given heparin can develop this dangerous type 2 HIT. And while 5% might not sound massive, you have to remember, heparin is used everywhere, in major surgeries, to treat DVTs, even just to keep IV lines from clogging up. That 5% adds up really fast. And this is why it's so terrifying. Of the people who get hit, up to half of them will go on to develop a new dangerous blood clot. Think about that, a 50% chance of a catastrophic complication. The stakes just could not be any higher. So how does this even happen? How does the body turn on itself like this? Well, it all comes down to a case of mistaken identity, where a simple protein and a common drug team up to create an absolute perfect storm. This quote from the research really just says it all. It creates a continuous cycle. It's like a runaway train. Once this process gets started, it just feeds on itself, getting worse and worse. And the only way to stop it is to cut the fuel line. And that fuel is heparin. All right, let's walk through this chain reaction step by step. First, heparin bumps into a protein that your platelets release. It's called platelet factor 4, or PF4. They bind together and form a new little combo molecule. Second, and this is the critical mistake, your immune system sees this new heparin PF4 complex and freaks out. It thinks it's a virus or a bacteria and flags it as a foreign invader. So it creates these powerful IgG antibodies to go on the attack. Third, these antibodies latch onto the complex, and this whole new structure then grabs onto other platelets and violently switches them on. And finally, these activated platelets go into total overdrive. They release more PF4, which grabs more heparin, and they spit out tons of clotting material, creating that vicious, self-sustaining cycle of clotting. You can see how quickly this can spiral out of control. Because of that, diagnosing HIT is like a high-stakes detective case. Clinicians have to act like investigators, hunting for clues and making a call really, really fast, often before they have all the evidence back from the lab. The first tool in their detective kit is something called the 4T score. It's basically a clinical checklist. Doctors look at 4 key clues. The first T is thrombocytopenia. How much did the platelets drop? Second is timing. When did it happen after the heparin was started? Third is thrombosis. Are there any new clots? And the last T is for other causes. Could something else be explaining this? You add up the points, and you get a score that tells you the probability of hit. And here is the single most important rule of this whole process. If that 4T score is a 4 or higher, meaning an intermediate or high probability, you do one thing, and you do it right away. You stop all heparin. Period. You don't wait for lab tests, you don't hesitate, the risk is too high. Okay, so while you've stopped the heparin, you send blood work to the lab for the forensics. There are 2 main tests here. Think of the ELISA tests like casting a wide net. It's really sensitive at finding those rogue antibodies, but it can sometimes pull in false positives. Then you have the SRA test, the serotonin release assay. This is the definitive proof. It actually tests to see if the patient's antibodies can actually make platelets activate. It's slower, it's more expensive, but it's the undisputed gold standard for confirming HIT.
So once HIT is on the radar, the entire focus shifts to breaking that dangerous chain reaction. And in a situation this critical, knowing what not to do is every bit as life-saving as knowing what to do.
Now, this is where things get really fascinating because all the rules seem backwards. Your gut instinct for a patient with low platelets might be to give them a platelet transfusion, right? But in HIT, that is the worst thing you can do. It's literally like throwing gasoline on a fire. You're just giving those rogue antibodies more fuel. And starting another common blood thinner, warfarin, can actually make the clotting worse at first. And of course, it goes without saying, no heparin, not even the tiny amounts used to flush an IV line. So, what are the right moves? Well, first, as we've said a dozen times, stop every last trace of heparin. Second, you have to immediately start a different, non-heparin blood thinner. The body is in a state of overdrive, trying to form clots, and it needs to be protected. So doctors will use drugs like argatroban, bivalirudin, or one of the newer oral anticoagulants to safely get the patient through this incredibly dangerous period. Making it through that acute phase of HIT is a massive win, but the story isn't quite over. The road to a full recovery has to be managed really carefully because the danger from those antibodies can actually linger for weeks or even months. This timeline does a great job of showing what that recovery looks like. So the platelet count might get back to normal in about a week, and you'd think, great, we're in the clear, but you're not. You're in what's called the subacute A phase. Those dangerous antibodies are still circulating and are fully capable of causing clots. It isn't until around day 50 on average that they lose their punch, and it can take almost 3 months before they're gone from the body completely. And because that risk sticks around for so long, patients have to stay on a safe anticoagulant well after the crisis is over. If a patient had HIT but was lucky enough not to form a new clot, treatment usually lasts for about a month. But if a new clot did form, that's a condition we call HITT. Then you're looking at a full 3 months of anticoagulation, at a minimum. When you step back and think about it, HIT is just this incredible, dramatic example of the immune system going rogue, a system designed to heal us, turning harmful. It really forces us to appreciate just how delicate the balance is inside our own bodies. And it points to one of the biggest challenges in modern medicine. How do we design treatments when the most unpredictable variable of all is our own complex and sometimes very confused immune response?